This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. An intraoperative surprise which was not expected, and I will take you through the step-by-step thought process which I had when I planned every next move to deal with this intraoperative zonular dialysis. So come along. The surgery is being done under topical anesthesia. The patient has undergone pterygium surgeries few years back. The side port incisions are made and the capsule is stained, and now is the time to perform the rhexis. The capsule is punctured. The bag seems to be just a bit wobbly and tearing is not very easy, but nothing very remarkable. I'm aiming for a rhexis of about 5 mm. I presume it is turning out to be slightly smaller than what I intended it to be. The last bit of the tear has to be completed and the rhexis is done. So nothing very striking at this stage apart from the bag being a little bit wobbly. The OVD is burped out, and now as soon as the OVD is burped out, I can see a clear zone in the subincisional area. At this stage during surgery, this had escaped my attention. Only when I did the hydrodissection and trying to push the nucleus down did I realize that the zonular dehiscence is present there. I'm trying to decompress the bag by pressing down on the nucleus, but the bag is refusing to get decompressed. The bag is tensed. The gross zonular dialysis which is there is very evident. At this stage, it looks like it was a pre-existing zonular dehiscence which was not picked up at the slit lamp, and now it is present in full glory. And it's about 3 o'clock hours. So I just want to go back and tap the lens and try to center the bag, but nothing seems to work. There is a clear zone between the bag and the iris, and you can see the red glow coming through it. And let me pause here. Question number 1. Now, why do you think that the bag is displaced? Of course, there is a zonular dialysis, but the bag seems to be displaced away from the area of zonular dialysis. What do you think is causing this? Is it just the zonular dialysis itself which is pushed the bag away, or is it something else? Whenever you notice that initially the bag was alright and then it has displaced away from it in the event of a zonular dehiscence in a localized area, always the first thing is to rule out vitreous prolapse to that area. That is transzonular vitreous prolapse. The first thing, put in triamcinolone acetate, and lo behold, we could see the culprit. So we have the vitreous prolapsing in all its glory now. So now I have got 2 questions. Number 1, should I deal with the vitreous first, or should I place the capsule securing device first? Well, it's always better to deal with the vitreous first. It's critical to understand that whenever there's a vitreous prolapse, it is the first thing to be dealt with. And you're going to consider putting the capsule stabilization device only after the vitreous is dealt with. Question number 3. Would I want to deal with the vitreous to the anterior limbal route or to the pars plana approach? Because by going through the pars plana, you're going to cut and suck the vitreous from behind, whereas from anteriorly, it may be difficult. For me, in this particular case, anterior limbal route would be a much safer option, simply because the cataract is opaque and I'm not an expert vitreoretinal surgeon. So there could always be a risk of touching the posterior capsule when I'm trying to do it in a slightly blind procedure. So initially, I would always like to do through the limbal route. Maybe when the cataract is out and there is a vitreous prolapse, then as well, I would still consider doing a pars plana approach at that stage. So let us proceed with the vitrectomy. So before proceeding to vitrectomy, always check whether the cutter is working or not. Put in a blob of viscoelastic on the surface of the conjunctiva and ensure that it is cut and aspirated. And begin by doing a slight vitrectomy near the wound so that you realize that it's cutting and aspirating well. Then I go in through the 2 side ports, one for infusion and one for the cutter, and then begin my cutting. So during vitrectomy, what should be my chief concerns? Apart from cutting the vitreous, my objective should be that I don't damage the collateral structures which are very nearby, like the rhexis margin or the pupillary margin. The rhexis being very critical, because if the rhexis is cut and the continuity is sacrificed, then my opportunity to put a CTR is lost altogether. In fact, the game is lost if you touch the rhexis margin. So that should be in the back of my mind, that I should be able to take care of the vitreous which has come across the zonules without touching the anti-capsule. And to achieve this, the secret is to have an extremely low flow rate and vacuum, because this is a peristaltic pump. This is a Centurion phaco machine. So I have a flow rate set at 10 so that the attraction of the tissues is very limited and I can know what I'm cutting. So that is the secret here. It takes a little bit longer time, but it's worth it. You are under full control of the tissues which you are cutting and which you are avoiding. So under high magnification, I ensure that the anticapsule and the pupil are spared, and it takes maybe a 5-minute job to ensure that the entire anterior prolapse vitreous is taken care of. The next agenda would be to stabilize the bag. Now, there are two options. Would I want to use the capsule hook first, or would I want to use the CTR first? The popular answer always is to use the capsule hooks first, simply because we can always insert the CTR later. If we insert the CTR early, there is always a difficulty in cortex aspiration. And the second thought would be, what would happen if there is an unfortunate PC tear? So these are the two reasons why many people defer the CTR to a later stage. Well, my thought process is slightly on the opposite side. I would always push in the CTR first and then take a call. If additional support is required, I would always go in and use a capsule hooks. The reason for using CTR first is that it is going to provide these zonular support in this area, and because the bag would be expanded now, I believe the chances of recurrent vitreous prolapse will be minimized. It will still be there, but it would be for a lesser extent. That's the primary reason why I would want to put in a CTR early enough. So rather than using the capsule hooks initially itself, we have to make additional few ports and then put in capsule hooks. I would rather put the CTR first and then the capsule hooks later if need be. Now, what about the cortex aspiration difficulty? I don't find cortex aspiration such a big deal with the CTR inside. One has to just use a tangential way of stripping the cortex, or you can just repeat hydrodissection. It loosens the cortex and you can aspirate it. The second advantage of putting a CTR early is there's always a chance of fluid misdirection happening and inducing positive pressure. Again, because the bag is pushed back in this area, the chances of fluid percolation across the zonules into the burger space is slightly minimized. That's one more reason why CTR has to go in early according to my plan. Now, how do I place the CTR? Should I use a manual method or a injector method? Well, either method would be fine. In this case, I'm using an injectable CTR. So what size the CTR should I use? The white to white was 11.5. So in this patient, I've used a CTR of which is 11 and 13 millimeter. To put in the CTR, I need to visualize the anticapsule well. But frankly, the visualization is very poor. The stain of the anticapsule has gone off. Now what we are seeing is after the color correction in the video editing tool. But in the microscope, this is how my view was. I was not able to see well at all. Because there is cortex all around, the lens matter, visualization of the anticapsule is slightly tricky. So in this case, what I'm doing is I'm going and restaining the capsule with just a little bit of dye. And these are the few tricks to restain to ensure that it doesn't go into the vitreous cavity. Number one, use only few drops of trypan blue in a soft eye. Always press on the posterior lip as we're injecting. Even when the dye is being flushed out, always I press down on the posterior lip of the main incision so that the fluid along with the dye just flows out of the eye rather than goes across the zonules into the vitreous. So now the visualization is slightly better. I can really see where the CTR is going. So few tricks here to ensure a smoother insertion of CTR. Number one, aspirate the cortex under the capsule just a bit and then put in cohesive OVD under the anticapsule to create some space. So in this case, I'm using a injectable CTR. It comes in two options, the left side opening and the right side opening. And in this case, because the left side needs to be supported first, I'm going to use the left-sided one, and slowly but surely it is threaded under the anticapsule and it is gently dialed in. The last part needs to be disengaged. Now the bag is supported by the CTR. Now once the CTR is in place, you can see that the bag looks to be stable, and now is the time to proceed with the phacoemulsification. The initial sculpting is done to make a vertical groove. And now I'm trying to rotate the nucleus. Unfortunately, I'm finding it difficult to rotate the nucleus. The nucleus is slightly on the softer side, and the hydrodissection might not be very effective, and I'm scared to really rotate the nucleus much. So I want to emulsify the nucleus without rotating it much. So the strategy which I'm going to use here is a cross sculpt technique, and just to ensure that the left hand heminucleus is divided into two quadrants. The sideways sculpting is a technique which I learned from Dr. Saurabh Patwardhan, and it works well in situations where you don't want to rotate the nucleus. Then slowly and surely the distal quadrant is held with the phaco probe and prolapsed out of the bag into the antechamber, and now it is emulsified in a very controlled manner. So the logic here is I want to use as minimal rotation as possible. And now one quadrant is out. So we have got one large quadrant on the right side and another half quadrant in my left side. The next question, which quadrant should I emulsify first? In this case, I consciously decided to leave my left hand quadrant in place. The idea is it's going to support the bag till the end. So I'm going to tackle only the right side of the heminucleus first. I go in with my phaco probe using very low longitudinal energy. Just give a short burst of phaco to bury it and then pull it out of the bag. Once it's out of the bag, it's going to be emulsified in a jiffy. So now the last quadrant, which is the left side, is being pulled out. So this was kept in place to provide some additional support to the area of zonular weakness. Although the CTR has already been put in, but still the nucleus also does impart a little bit of support. So far so good. The rhexis margin is round, suggesting that the zonules are holding well. There is no evidence of any bag displacement as such. But what I'm feeling now is that the posterior capsule is being pushed forward. I suspect there is some amount of fluid misdirection happening. So cortex aspiration is going to be a challenge, simply because the posterior capsule is convex and there is every risk of causing a PC tear. So I fill in the bag with OVD, that is HPMC, and then using in a very controlled manner, I'm trying to strip off the cortex. So when we have a CTR inside the bag, the best approach to deal with the cortex is always try the tangential way of stripping if the radial extraction doesn't work. So in this case, some quadrants I'm just doing the radial way of stripping, but sometimes you may have to resort to the tangential way of stripping the cortex. So at this stage, I feel that the posterior capsule has come up and there is no space for me to do the aspiration. So I'm going to inject some OVD into the bag so that it creates some space and maintains for a slightly longer duration of time. So in such cases, patience is the key, and most often what happens is once we have done the critical part, that is taken care of the nucleus and all, our concentration level dips, and there is always a higher risk of causing PC tear during these maneuvers. So one needs to be mindful, especially in this scenario, because of the fluid misdirection, the posterior capsule is turning up, there is an enormous high risk of causing a PC tear. So I am going to tell myself that it is really not over yet. I'm just going with my hydrodissection cannula, trying to flush the posterior capsule gently so that it loosens up the cortex, and slowly but surely, eventually every bit of cortex is removed. So that was good. Now, the next question. So this video is all about questions. They're never ending. Now, should I continue and implant the planned toric lens, which is single piece obviously, or should I just go back and implant a multi-piece lens, 3-piece lens, like with the haptics in the sulcus and the optics in the bag, which I typically do for my pseudoexfoliation cases, which ensures long-term stability. The pre-existing astigmatism is around 2 diopters, which is against the rule, and it's quite significant, and this needs to be corrected with the implant toric lens. Now I need to decide whether the stability of the bag presently with the CTR inside is good enough to support this lens for a reasonably long duration of time. So looking at this situation, the stability of the bag with the CTR inside, I thought that this bag would last for quite a significant duration of time. So I decided to go in place the toric lens time to implant the lens, but I've noticed there is vitreous lurking around in the vicinity of the side port incision. So again, before putting in the lens, I would just go back and deal with this vitreous first with the vitreous cutter. And you know what? Dealing with these single fibers of vitreous is much more difficult than dealing with a large quantity of vitreous prolapse. These single fibers are so frustrating, we can't reach them. And you're trying to be aggressive to try to reach, there's always a risk of damaging the iris or the anterior capsule. So I need to be very, very careful and mindful. And you need to change the angle of attack, sometimes from the side port, sometimes to the main incision. Eventually it is taken care of. The chamber is now filled with OVD. So I'm using a cohesive OVD to fill in the bag as well. The lens is implanted into the bag. And now the OVD which is there behind the lens has to be removed out. Again, this is a challenge because there is no space, the axis is small. Lift the lens up, continue irrigation, and it takes maybe half a minute for the OVD to be burped out. And now is the time to flush out all the OVD in front. Again, I need to recheck for any vitreous lurking around in the wounds. So triamcinolone acetate is used, and unsurprisingly, there is some vitreous which is prolapsing out through the zonules, and I need to take care of it. At this moment, I was seriously consider going through the Postoperative approach and to deal with this because the vitreous prolapse seems to be quite relentless. But I said, let me try one more time. If it doesn't, then I'll have to go through the Postoperative approach. Now the media is clear. I can see, visualize very well. It's not going to be difficult for me to go through the Postoperative. But again, I need to make an extra port. I'm just trying to see whether it is possible to the limbal root itself. It looks like the vitreous is now taken care of. Now the lens has to be gently dialed in position. With the irrigation in my left hand, the lens is dialed in to be placed in the desired axis, which is around 5 degrees. Once it is done, try to close. I want to use a pilocarpine, just a couple of drops to bring down the pupil. That's going to help me to identify any pupil peaking and take care of any prolapsed vitreous fibril. Thankfully, there is none. So now, until your last step, always keep an eye on the vitreous fibril because they'll surprise you. They can come from any quadrant, especially when in these transzonular vitreous prolapse. So try to be there. I'm not sure whether there is vitreous. I'm just trying to hold the cutter there and keep cutting so that I'm not missed out any vitreous fibril. So finally, it looks good. The ports are hydrated. The pupil is round. Intracameral antibiotics are placed inside. The eye is patched and the patient is put on oral acetazolamide to take care of any pressure eyes. And these are the first day post-op pictures. As expected, because of the manipulation, there is some corneal edema. The pressure is around 18 and hopefully she'll improve in the next couple of days. These are the post-op pictures in the 3rd day and the 10th day. On dilatation, the lens looks to be well centered. The refraction is alright. So eventually it was a reasonably good outcome. To summarize, this was one case where I had an intraoperative surprise, which I was not expecting. But the point here is, if you take just a moment to think over and plan out the subsequent steps, things would become much more easier to manage. When faced with a surprise, planning becomes extremely important. Take a moment to plan for every other step and anticipate for all the things which can go wrong. This is the key to ensure that the case subsequently becomes much more predictable and one will be surprised that the outcomes will be excellent. So that was it. Thank you for watching and hope you found this helpful.